Thanks for joining us today for Ask the Mayo Mom. I'm Dr. Angela Mattke. We're going to pause for a couple of seconds to let the audience build. While we're waiting, I want to tell you a little bit about today's topic, which is going to be hypoplastic left heart syndrome, which is also known as HLHS. HLHS is a rare type of cyanotic congenital heart disease where the left side of the heart is underdeveloped. The treatment of hypoplastic left heart syndrome is palliative care only. Congenital heart disease is when an infant is born with something wrong with the structure of their heart. So for those of you that are just joining us today, this is Ask the Mayo Mom on Mayo Clinic's Facebook Live. Again, I'm Dr. Angela Mattke. I'm a pediatrician and mom at the Mayo Clinic Children's Center in Rochester, Minnesota. Each month, I host a Facebook Live interactive show about pediatric health topics. Since February is American Heart Month, we will be focusing on the pediatric aspect of this. Both broadcasts this month will pertain to congenital heart defects and congenital heart disease. My guest here today is Dr. Tim Nelson. He is the director of the Todd and Karen Wanek Family Program for Hypoplastic Left Heart Syndrome. Dr. Nelson, along with a multidisciplinary team of physicians, scientists, and many other experts, are working to find and apply innovative solutions to the treatment of hypoplastic left heart syndrome. So, Dr. Nelson, thank you so much for joining us here today. I'm very excited to hear more about what your program has been researching and studying to try and change the outcomes of hypoplastic left heart syndrome.
Thanks for having us. This is a pleasure to be here and an opportunity to share what we're working on in the program with many people that watch your program. So thanks for having us.
Awesome. Well, thanks everyone for joining us. Let's get started. I would like, if you could start to describe a little bit more about hypoplastic left heart syndrome so we have a good foundation to kind of build on all of the research and exciting things that you guys are doing.
Sure. Hypoplastic left heart is the most severe congenital heart defect that children can be born with. It literally is the left side of the heart is absent when they're born. This side of the heart is actually what causes the blood to pump to the entire body, and when it's absent, it requires surgery to be done very early in life. Children typically have to have surgery done within the first few days of life, first 3 months of life, and then again when they're 3 years of age. So it's a devastating diagnosis when people first get it, but there's a lot of hope and there's a lot of very remarkable clinical practice that allows these children to have much better outcomes today than they've ever had before.
Absolutely. We have a graphic here to kind of help people understand what the difference of HLHS is compared to a normal heart. So can you just explain a little bit about this graphic?
So the normal heart has two chambers that pump blood, one to the body and one to the lungs. The red chamber here on the normal side is the chamber that pumps blood to the whole body. And the blue side is the chamber, the right ventricle, that pumps blood to just the lungs. We like to think of this as kind of the 100 horsepower engine and the 5 horsepower engine working together. And the problem with hypoplastic left heart, or HLHS, is you can see that red pumping chamber, the 100 horsepower engine, is actually very small and prevents the heart from doing its normal workload. And so what the surgeries do is basically reconstructs the plumbing of the heart to allow that small 5 horsepower chamber motor on the right side. It has to do the work now to the entire body. And we like to refer to that, it's sort of like having the 5 horsepower engine and putting it into your SUV and causing you to drive to work every day down the interstate. At some point, that little engine will likely fail. And our goal is to figure out why and how it will fail and see if we can prevent and delay that.
Absolutely. So how is HLHS diagnosed? Is the timing of diagnosis important or critical?
It absolutely is. The far majority are diagnosed with routine ultrasound screening starting at about 20 weeks of gestation in a pregnant mother's life. This is the best way to diagnose it because it gives us time to prepare for what's coming. The challenge is that sometimes 10-15% of the time we don't diagnose it in utero and we find out after they're born. And that is something that we want to work collectively to avoid.
And across the United States, we've changed screening for what we call critical congenital heart disease lesions, and we've been doing that. And recommendations are that all states are using a simple screen by just looking at pulse oximetry.
Exactly.
And I would assume that some of the children maybe being picked up from that, if not earlier, based on how they're doing?
We would hope we catch all of the remaining
Yes.
babies that we miss in utero with that easy screening that most places are routinely doing now.
So, as you mentioned earlier, the treatment is, considered palliative. Can you tell me a little bit more about what that means?
It's kind of a difficult word to use, palliative, and what we mean by that, it's commonly used, and it means that the surgeries that we do are really designed to make this 5 horsepower engine do the best it possibly can. And for some children and young adults, this small engine does really, really well, and they can have a remarkable outcome, and they do fantastic. And we wish everybody had that outcome. The reality is, many people have a problem with that small engine, and so we don't have a cure for this disease today. And that really is what drives the research and the inspiration and the motivation for what we do in our program, to say maybe there's better technology available today in the science and in the labs that we can begin applying to this clinical solution to make these hearts stronger.
Absolutely. You mentioned earlier that there's usually a series of 3 different surgical interventions. Can you explain those in a little bit more detail? Because I think if we understand the names of those, discussion later with some of the new treatments will be
The 3 terms
helpful.
that typically are used is the Norwood operation is the first surgery that's done within the first few days of life, and that's the big operation. It's the intimidating one because you have a young baby. It's only a few days old, and it's done in an urgent setting soon after birth. The Glenn operation is the one that is the second surgery, typically 3 months of age. And then the third surgery, or the Fontan surgery, is done when they're 3 years of age or older, and that kind of completes the circuit that allows the heart to do its best possible with this small right side of the ventricle.
Okay. As you mentioned earlier, some of the children do really well with that small horsepowered engine or ventricle, and some of them go on to struggle and have more medical problems and complications. But there's more than just with heart that may be related to this. There's other medical complications that they may be dealing with. Can you discuss a little bit more about what those might be?
Anytime the heart doesn't pump blood as well as we want it to, it causes other tissues and other organs to start having problems. It's very common that the liver ends up having some dysfunction and doesn't function as a normal child. And so we have other tissues, and like the liver and the gut, that we also worry about. And we believe that if we can make the heart stronger and try to make the heart prevent it from failing, that we could also have an impact on those other tissues.
Okay. As you mentioned earlier, many children and adults will do well for a period of time, or for a longer period of time, more and more with new advances in medicine. Will all children or children who have become adults with HLHS go on to develop some form of heart failure?
So again, because we call it a palliative, we do our best with what we have, and the surgical interventions and the medical care in the last 2 decades has really been remarkable. Before 1980, if somebody was diagnosed with this condition, they would not survive because we didn't have the surgical treatment options for them. So it's really only in the last 3 decades that we've been able to start doing things that we couldn't conceive of prior to that. However, it is frustrating to us in the medical profession to see too many of these children have heart problems, heart failure, and maybe even have to go on to a heart transplantation at some point. So it's very clear that our mission of our program is to delay or prevent transplant and heart failure for these kids, and try to make the small minority of kids that do well become the majority by doing other things. And that's our hope. It's a devastating diagnosis, as we talked about at the beginning, but there is hope with current treatments and with the future treatments that we're working on that makes tomorrow even brighter than it was yesterday.
Okay. As I mentioned earlier, you are the director of the Todd and Karen Wanek Family Program for Hypoplastic Left Heart Syndrome. So big name, but you guys are also doing really big things. So your website describes, and I want to use this description because I think it really is highlights what you're doing. So it's a collaborative network of specialists bonded by the vision of delaying or preventing heart failure for individuals affected by heart disease. And you guys are taking a multifaceted approach to your research. And I really want to get into all the different areas of research you're doing. So some of them are imaging and outcomes. So other areas are genetics. And then the last area, which I think is really exciting, is getting a lot of press, is the regenerative strategies to try and prevent or delay that heart failure that may ultimately develop. So as we discussed earlier, we don't necessarily know what causes HLHS. So your team is trying to figure out and identify what genes or what molecular pathways might be involved. Can you tell us a little bit more about how you're studying this and tell us about that biorepository that you're using?
Sure.
Yeah.
So this really started in 2010 with the visionary leadership of Todd and Karen Wanek and their family, who have a personal story that they have shared publicly of how this condition has impacted their lives. And they challenged us as an institution to try to bring together a team of people to transform the way we care for these children. And to do that, we recognize that we have to have a better understanding of what causes the condition from a genetic standpoint. How can we predict when the heart might end up failing and try to intervene as soon as possible? And ultimately, we believe that regenerative strategies were ready to be able to translate into clinical trials to start pushing the field forward in this area. And it's really that multidisciplinary team that makes this possible, and in the spirit and the culture of Mayo, that the needs of the patient come first, and we do whatever it takes to innovate on new fronts, really allowed us to galvanize a really remarkable team. I'd also like to say that in addition to that team of experts, we have teams of families and patients that we can't do what we do without their involvement. And so when we say a multidisciplinary collaborative approach, it also really speaks to the fact that these families are critical. We can't do it without them.
Absolutely. Not only the research, but the support and spreading
Absolutely.
the information and the knowledge that they're helping with. You guys also have every year a big rally called Feel the Beat. Can you talk a little bit about that?
Yeah, we love Feel the Beat. So Feel the Beat was inspired by our heroes, which are these children. And too often the children never get to see how their research and samples that they've donated or what the scientists do with it. And in return, the scientists don't get a chance to interact with these patients very often. So it's a really remarkable opportunity to bring together the physicians, the scientists, the team members, and the families into one event. It's a blast. It happens every year in October, and we're looking forward and starting planning next year's event. But in doing that, it's really the samples, the DNA, the blood that these children and family donate to build the biorepository. And that creates the foundation on which we can stimulate all kinds of new research ideas. And that's leading us to learn more every day about what causes the condition and therefore how we can better intervene to try to find a curative solution.
Okay. So you mentioned blood and tissue samples.
Yeah.
Is there anything else that you guys are collecting in this biorepository?
So we'd also put in that biorepository the imaging, the echoes and the MRIs, and that natural history of what families go through year to year. And that allows us to integrate the imaging and clinical history with the genetics and the stem cells. One particular thing that we do with the stem cells is we can start with a piece of skin, an ordinary skin biopsy, and we regenerate that into what's called induced pluripotent stem cells. They're basically making seeds out of your skin that can grow into any part of your body. And the part that we obviously care the most about is the heart. And so in the lab, we can bioengineer your heart from a piece of skin. And that creates a platform that allows us to study how drugs respond to your heart, how your heart responds to stress. And it allows us to start understanding the differences between why one child might have a really great outcome and another child might have less of a good outcome. And so it's this biorepository that we think will continue to fuel the innovation as we go forward.
Have you been able to use those specific pluripotent cells to study it for individual children in regards to their response?
We are starting to see individual families that have a genetic mutation that we think is causing the HLHS, and we can start mapping in the cell culture of how those cells are behaving differently from mom and dad. So we've done this on over 300 individuals now. It's the world's largest repository of iPS cells and genetics, and it really creates an opportunity for not only our scientists here at Mayo, but even collaborating scientists around the country and world to really help us use this rich resource to understand what is causing the disease.
Okay. You mentioned regenerative strategies, and I mentioned it earlier, so I really want to get into talking about this. So regenerative medicine strategies for HLHS have the potential to help with delaying that heart failure, maybe preventing heart transplantation by helping regenerate the heart. What is regenerative medicine, just as a definition by its whole?
So we like to say regenerative medicine is essentially the opposite of degeneration. So if you think of the degenerative tissues that some of us have in our hips and knees and other joints, regeneration is the idea of trying to renew the tissues. If you cut your skin, you take it for granted that you'll heal quite quickly. And there's multiple tissues in our bodies that are able to naturally regenerate. The heart is able to regenerate at a very small level, more when you're young, less when you're old. And regenerative medicine is really trying to understand those biological principles to make the heart, to be able to augment that heart regenerative response. And the way we do that right now is by using cell-based therapies to do that.
Okay. There's a lot of confusion sometimes when people hear the word stem cells.
Yeah.
Can you kind of help us understand what type of stem cells you guys are using?
Yeah. So there's 4 types of stem cells, and the first one is embryonic stem cells. We do not use embryonic stem cells for multiple reasons, but other types of stem cells such as bone marrow derived cells or umbilical cord blood cells or the bioengineered stem cells that we talked about a little bit, those cells don't destroy or use any embryonic tissue, and that makes them completely different. So sometimes the word stem cells does get confusing of what we mean. In our case, we use the word stem cells for cord blood, and for bioengineered is what we refer to it.
Can you use a person's own stem cells in helping with these treatments?
Yeah, and we think it's important to use a person's own stem cells to avoid immunological mismatch by using other people's cells into the body. And so we use autologous, or cells from your own body, cord blood, and we collect cord blood from each individual child and process and use those cells in our research. We can also collect stem cells from a patient from their bone marrow if cord blood isn't available.
Okay. We have a picture up here of umbilical cord blood banking, so we can show a picture of what that is. Can you explain to us a little bit more about what the umbilical cord blood banking is and how you guys are hoping to collect this from all children with HLHS in the United States?
Yeah, so as you can see in this picture, every baby is born and we clamp the cord and cut it. When that happens and the baby is born at that point, the cord is still connected to the mom's body at that point, and we can simply insert a needle into that cord and start draining the blood out. That happens after the baby is born. It has no impact on the baby at that point, and we do it before the placenta is discarded at that point, and we collect as much blood as we possibly can. We have a kit that we can send out to anywhere in the country to be able to collect this, and then it can come back to us here in the program, and we process it and we store it, and we make that available for the research studies that we're doing.
And that blood would be used then on that specific child later on, or would it be used for other children?
Great question. We say that we are collecting it for the child themselves, and we use it and keep it for that autologous or application for the child, and that's what the intentions of this process to do that. And that's why it's important for us to begin collecting as much of this cord blood and processing it as possible. And we now have the infrastructure and the facilities to be able to work towards collecting all cord blood on all of the 900 plus children that are born in the United States every year.
We have a great question about this. So this parent says if they did not collect cord blood from their child who currently has or was born with HLHS, could they use stem cells from a sibling's cord blood to be banked?
It's a great question. We tend to right now prefer to use bone marrow from that child that is living with HLHS. The cord blood from a sibling could be a good match, but it might not be a good match just based on the genetic profile of it. So it doesn't necessarily add additional value for cord bloods that we could collect from other people. Right now, we really are focused on the baby's own cord blood or bone marrow if they don't have the cord blood.
Can you talk a little bit about what research studies you're currently using these stem cells in children with HLHS?
Yeah, so we have 2 ongoing clinical trials right now. And clinical trials means that we've done the safety and feasibility testing in the lab, and we have FDA permission to begin testing this in our patients. And so we have 2 clinical trials. The first one is the umbilical cord blood from the child collected at birth and processed, and at the time of the Glenn operation, we can deliver the cells directly into the heart muscle with the hope of making the heart bigger, better, and stronger. but it's a 10-patient clinical trial to make sure that we can do it safely and we can feasibly do that. That's the first study that's ongoing and currently open for enrollment. And the second study is more for post-Fontan patients that have developed some cardiac or heart problems that are not normal. We can collect their bone marrow now, process it, and deliver it in a catheter-based procedure, which we go into the heart in a catheter-based approach, not requiring surgery, and delivering the cells that way. So those are the two studies for the Glenn patients with cord blood and the Fontan patients with bone marrow that we're currently doing.
Okay. We had a couple questions that had come in from Connect specifically about the Glenn, the timing of the stem cells being used for the Glenn and Fontan time. So hopefully that helped answer those questions. We also had another question. Can you go right back up? And this question was, I think you answered it well, but I just want to make sure it's clear. Are stem cells to be used just on newborns, or are there other treatments for older children or potentially young adults with HLHS? Are you looking at using these stem cells on young adults or older people, survivors with HLHS?
It's a great question, and we get this a lot, and it's important to understand that even though we've started with these two studies that I've said so far, our appetite, our vision, and our plan as a program and as a collaborative group of physicians and scientists is to continue to find ways of accelerating and bringing these cells to additional people. The big group of people that we obviously are aware of is the Fontan patients that may end up developing reduced heart function. And we want to have multiple options available for them. And so we think of the cord blood and the bone marrow as kind of being low-risk cells that have been used a lot in adult patients for regenerative medicine that we're repurposing for pediatrics and using those as readily as we can. But there's other cells like the bioengineered cells that we also are working towards in the future to be able to begin using those to remuscularize the heart. And so those would be available potentially for any age, whether they had cord blood collected or not.
So going back to the cord blood that you said that you can send it out to any parent, and so it can be collected at the time of the birth with a child. How would a parent get in touch with you guys? I know you guys are really active on social media and on Mayo Clinic Connect. Can you tell us a little bit how they can reach your program?
Yeah, the best way that people can connect with us is through our email. It's HLHS at mayo.edu. So that email address is as simple as it can get. And we monitor that continuously, and that's a great way to connect, and we can triage the questions into the right hands who can answer it best. But that's the portal that is one way to get connected with us to be able to start launching the process that it takes to collect the cord blood.
Okay. We had another question about what percentage of children who have HLHS will end up with liver damage or liver-related issues or liver failure. We want to know how common that is. Is that something you're able to answer?
Yeah, it's an extremely common situation, and so it's always sometimes a surprise to families when they find out, I thought I was a heart patient and now I have liver problems. Right. The liver is not normal in these babies and young adults with hypoplastic left heart. We're learning more about that, and there's more better treatment guidelines of how to follow these other problems as we go forward. But people should know that it's not uncommon that their doctor will tell them that there's also some liver abnormalities. And is that a very serious thing, or is that just kind of within the norm of HLHS is what we have to think carefully about.
Okay. So another great question about the regenerative medicine and the stem cells. So they're wondering how many patients have been able to complete the stem cell delivery in the post-Fontan patients in the cath lab. But I think the catheter was not post-Fontan.
It is,
actually. Or was that post-Fontan? Okay.
Yep.
And then they said, when do you anticipate that this may be FDA approved?
Yeah, so we've had 4 patients out of the 10 complete the catheter-based bone marrow-derived cells into the Fontan patient. Okay. And that's a 10-patient study that we are continuing to try to enroll and complete. Hopefully this year we can find a conclusion of those 10 patients and compare those to patients that didn't get the stem cells. The goal of those is to show that it can be done safely, hopefully that there's some efficacy, meaning the heart gets better as well. And with those 10 patients, we're going to learn a lot. And we're going to learn, can we go more quickly with this, or do we need to retool it and find another way? So the goal is to complete that study as quickly as possible, learn from it, and really retool it to know where we're going. our hope would be that we would see not only that it's safe, but we can start showing that it can be effective. And that would design other studies that we would hope to accelerate with the goal of making it FDA approved, as you said, which would then make it available to any patient with this condition anywhere. And that is exactly what we hope to be able to drive forward.
There's another really interesting area that you guys have been working on. You've been very innovative in trying to find ways that you can help your patients be able to provide information about their health. And one of those was by creating a free app available on iTunes. And this was done with Sisters by Heart and Empathia, thank you. And it's called the HLHS Health Journal. And we have a picture of it here if we could have that pulled up. Can you tell us a little bit more about this app and what it can do?
All of the mothers and families that are connected with us today that have gone through this process will know that during the interstage between the Norwood and the Glen, they're asked to collect their heart rate, oxygen, body weight every single day. They call into the nurse once a week to report these values. And this is literally a paper and pencil and a journal that we all do all over the country right now. This was an app to be able to say, let's digitize that and make this communication a little bit easier for the moms and the families at home. And this becomes a useful tool for our standard of care, but it also provides a portal for us to help disseminate information more rapidly, collect more information. And we love this idea of a data donor. We love the idea that if we can create tools with Sisters by Heart and other social media minded individuals, if we can get the community sharing their data, sharing their experiences with this objective data, we can maybe see better trends at predicting when things might not go as well as they should, and better intervene sooner than later. So we're super excited about this as a way of creating a research tool to better accelerate the knowledge that we need to innovate.
So you don't have to be a Mayo Clinic patient to be able to use this app right now?
Yeah, we made it a free in iTunes. The current limitations, it's on iPhones only, but we are working to make this more broadly available based on feedback that we get. But it is available, and we would encourage people to use it and share their data and give us the feedback, because we believe it's a portal to help do bigger things as we go forward.
Absolutely. No, they are able to share this directly with their physician then. And how is that done? Help us understand
it's
that.
It's a simple email function. So we believe that the patient should own their data. Institutions shouldn't own it. It's your data you collected, and you as a mom can decide who you share with it and when. And by doing it that way, it allows us to share it with as many people as possible. Our program would hopefully benefit from it, but there's other organizations and other research groups that would also potentially benefit from this data being shared with them.
Absolutely. Well, thank you so much for sharing all of the really innovative and exciting research that your team has been working on. I want to just finish up by asking you one last question about, would you have any advice for a family that's been recently told that their infant or their child that's in utero still has HLHS?
Yeah, it's a critical question. We all, no matter what we tell our families, everybody goes to Dr. Google and starts looking, and there's a lot of good information and not such good information out there. I think there's some really great groups like Sisters by Heart that moms to moms connecting and being able to have the connections with that. Our blog here at Mayo with the Connect is really designed to triage these questions and help get physicians and scientists involved when we can to answer them. And we also have a regenerative medicine consult service here at Mayo Clinic that is available to everybody, that we can actually set up a phone call with families to answer questions about research and clinical trials. And so there's multiple ways where families need to connect to try to get the more information, and know that it's a daunting few weeks when they get this diagnosis, but there's a team of us here at Mayo and a consortium that's forming that's really here to help and try to give the best information possible and try to get people engaged in the research that we need to do to find new solutions going forward.
So by educating themselves, knowledge is really power, and then being able to connect with other families can be very supportive because they've been through this and they know what you're feeling in those moments.
Absolutely.
So, well, this has been fantastic. Thank you so much for joining me today. I want to share with everyone else that may be watching, we will be having another discussion in 2 weeks on February 23rd. We'll be talking more about, from the cardiologist perspective, kind of ongoing treatment of congenital heart disease, not just HLHS, HLHS, and also talking about heart transplantation in pediatric patients. And that will be with Dr. Jonathan Johnson at 10 a.m. on February 23rd. Thanks everyone for joining us today. Have a great day. Happy Heart Month.